Hypertension is persistently raised arterial blood pressure. The current standard threshold for suspecting hypertension is clinic systolic blood pressure sustained above or equal to 140 mmHg, or diastolic blood pressure sustained above or equal to 90 mmHg, or both. The diagnosis is then confirmed with ambulatory blood pressure monitoring, ABPM, or home blood pressure monitoring, HBPM. Hypertension can be classified by stages or by underlying cause. Primary hypertension, which occurs in about 90% of people, has no identifiable cause. Secondary hypertension, about 10% of people, has a known underlying cause such as renal, endocrine, or vascular disorder, or the use of certain drugs. White coat hypertension is blood pressure that is unusually raised when measured during consultations with clinicians but is normal when measured in non-threatening situations. It is reported to occur in about 15–30% of the population. A white coat effect is defined by NICE as a discrepancy of more than 20/10 mmHg between clinic and average daytime ABM or average HBPM blood pressure measurements at the time of diagnosis, but is generally used to describe persistent discrepancy between clinic and home or ambulatory daytime averages in those being treated for hypertension and those who are not. Masked hypertension describes situations where clinic blood pressure measurements are normal, less than 140/90 mmHg, but blood pressure measurements are higher when taken outside the clinic using average daytime ABPM or average HBPM blood pressure measurements, certain drugs. Hypertension classified by stages. Stage 1 hypertension, mild. Clinic blood pressure ranging from 140/90 mmHg to 159/99 mmHg and subsequent ABM daytime. Average or HBPM average blood pressure ranging from 135/85 mmHg to 149/94 mmHg. Stage 2 hypertension, moderate. Clinic blood pressure of 160/100 mmHg or higher, but less than 180/120 mmHg, and subsequent ABPM daytime average or HBPM. Average blood pressure of 150/95 mmHg or higher. The upper limit of stage 2 hypertension is variably defined in other guidelines internationally. Stage 3 or severe hypertension. Clinic systolic blood pressure of 180 mmHg or higher or clinic diastolic blood pressure of 120 mmHg or higher. Stage 4, accelerated or malignant hypertension, very severe, is a severe increase in blood pressure to 180/120 mmHg or higher, and often over 220/120 mmHg, with signs of retinal hemorrhage and/or papilledema, swelling of the optic nerve. It is usually associated with new or progressive target organ damage. The risk factors for hypertension are as follows. Age. Blood pressure tends to rise with advancing age. Gender. Up to about 65 years, women tend to have a lower blood pressure than men. Between 65–74 years of age, women tend to have a higher blood pressure. Ethnicity. People of Black African and Black Caribbean origin are more likely to be diagnosed with hypertension. Coexisting diabetes or kidney disease. Lifestyle, smoking, excessive alcohol consumption, excess dietary salt, unhealthy diet, obesity, and lack of physical activity are associated with hypertension. Anxiety and emotional stress can raise blood pressure due to increased adrenaline and cortisol levels. Social deprivation. People from the most deprived areas in England are 30% more likely to have hypertension than those from the least deprived. Genetic factors. Research on twins suggests that up to 40% of variability in blood pressure may be explained by genetic factors. A positive family history increases the risk of developing hypertension. Secondary causes of hypertension. An identifiable cause of hypertension is more likely when hypertension occurs in people under the age of 40 years or worsens suddenly, or presents as accelerated hypertension. Stage 4, malignant. Consider investigating for causes of secondary hypertension if any of these apply, or if the history, examination, or investigations point to a possible underlying cause. Renal disorders are the most common cause of secondary hypertension, chronic kidney disease. This is the most common identifiable cause of hypertension. Hypertension may also be a cause of chronic kidney disease. Chronic pyelonephritis. usually detected unexpectedly on ultrasonography when investigating hypertension. Diabetic nephropathy, indicated by microalbuminuria or proteinuria. Glomerulonephritis, often indicated by microscopic hematuria. Polycystic kidney disease, suggested by an abdominal or flank mass, microscopic hematuria, or family history. Obstructive uropathy, the person may have an abdominal or flank mass. Renal cell carcinoma, classically the person may have hematuria, loin pain, and a loin mass. But increasingly, asymptomatic renal cell carcinoma is being picked up on ultrasonography or CT, computed tomography, scan. Vascular disorders, coarctation of the aorta, usually results in upper limb hypertension. There can be a significant difference in blood pressure between the left and right arms. Other signs include absent or weak femoral pulses, radiofemoral delay, palpable collateral blood vessels in the back muscles, and a suprasternal murmur radiating through to the back. Renal artery stenosis. Suspect this if the person has peripheral vascular disease and an abdominal brute, or if blood pressure is resistant to treatment. Most cases are clinically silent, other than hypertension, but the condition should be suspected if the plasma renin level is increased. Primary hyperaldosteronism, probably the most common curable cause of hypertension. People usually present with hypokalemia, alkalosis, elevated bicarbonate level, and plasma sodium level greater than 140 mmol, or a larger than expected decrease in serum potassium. When using a low-dose thiazide-type diuretic, the symptoms may be nonspecific, but rarely it may present with tetany, muscle weakness, nocturia, or polyuria. Treatment with a calcium channel blocker can mask the features of primary hyperaldosteronism. After identification of a possible adrenal adenoma on CT scan or magnetic resonance imaging, MRI, tertiary referral is required for confirmation of unilateral aldosterone excess and possible laparoscopic adrenalectomy. Pheochromocytoma. People can present with intermittently high or labile blood pressure, or postural hypotension, headaches, sweating attacks, palpitations, or unexplained fever and abdominal pains. Alternatively, it can be asymptomatic. Pheochromocytoma is rare, but an important cause of hypertension to exclude, because malignant transformation or catastrophic hemorrhage from these tumors can be fatal. Cushing's syndrome. Suspect this when clinical features are present, for example, truncal obesity and striae. It rarely presents as hypertension alone. Acromegaly. Suspect this if clinical features are present, for example, enlargement of hands and feet, facial changes, sweating. Hypothyroidism. Hypertension may result from altered levels of renin, angiotensin, and aldosterone, and is associated with an increased diastolic blood pressure. Clinical features may include fatigue, weight gain, dry skin and hair loss, constipation, and muscle weakness. Hyperthyroidism. Increased systolic blood pressure may result. Clinical features may include tremor, anxiety, sweating, weight loss, diarrhea, and heat intolerance. See the CKS topic on hyperthyroidism for more information. Alcohol. Misuse of alcohol may be the most common individual secondary cause of hypertension. Features include variable hypertension that is resistant to commonly used drugs and that disappears within a week or two of complete abstinence. Cyclosporin, cocaine, amphetamine, and other substances of abuse. Combined oral contraceptive, corticosteroids, erythropoietin, leflunomide, licorice, present in some herbal medicines, non-steroidal anti-inflammatory drugs, estrogens used in hormone replacement therapy, stimulants used to treat attention deficit hyperactivity disorder, ADHD, such as methylphenidate, atomoxetine, dexamphetamine, and lisdexamfetamine. Sympathomimetics may be found in over-the-counter cough and cold remedies, for example, ephedrine and phenylpropanolamine, venlafaxine. Other causes include hypertension in pregnancy, connective tissue disorders, scleroderma, systemic lupus erythematosus, polyarteritis nodosa, retroperitoneal fibrosis, obstructive sleep apnea. Hypertension increases the risk of a number of conditions, including heart failure, coronary artery disease, stroke, chronic kidney disease, peripheral arterial disease, vascular dementia. Hypertension is one of the biggest risk factors for cardiovascular disease and related disability. At least half of all heart attacks and strokes are associated with hypertension. There is a continuous direct relationship between blood pressure and adverse cardiovascular events, with higher risks at higher levels of blood pressure. Correction of high blood pressure, by drug treatment or modification of lifestyle factors, reduces these health risks. A systematic review and meta-analysis found that, in the population studied, every 10 mmHg reduction in blood pressure resulted in a 17% reduction in coronary heart disease, a 27% reduction in stroke, a 28% reduction in heart failure, a significant 13% reduction in all-cause mortality. Another large-scale analysis of randomized trials found that a 5% reduction in systolic blood pressure reduced the risk of major cardiovascular events by 10%, even at normal or high normal blood pressure values. Investigations. There are 3 things that need to be assessed: the cardiovascular risk, the target organ damage that has occurred, and finally, any secondary cause for hypertension present. 1. Assess cardiovascular risk for MI and stroke, a range measurement of serum total cholesterol and high-density lipoprotein HDL cholesterol. Q-Risk 3 Risk Calculator. This site calculates a person's risk of developing a heart attack or stroke over the next 10 years. 2. Assess target organ damage that may have occurred. Kidneys. A range measurement of urine albumin ratio to test for the presence of protein in the urine. HbA1c to test for diabetes. Electrolytes, creatinine, and estimated glomerular filtration rate to test for chronic kidney disease. Eyes. Examine the fundi for the presence of hypertensive retinopathy. Heart. Arrange for a 12-lead electrocardiograph to be performed to assess cardiac function and detect left ventricular hypertrophy. 3. Identify secondary causes. Consider the need for investigations for possible secondary causes of hypertension. An identifiable cause of hypertension is more likely when hypertension occurs in people under the age of 40 years, worsens suddenly, or presents as accelerated hypertension. Consider investigating for causes of secondary hypertension if any of these apply, or if the history, examination, or investigations point to a possible underlying cause. Hypertension diagnosis. Blood pressure can be measured manually or with an automated device. Manual BP. Measure blood pressure in a relaxed, temperate setting with the person quiet and seated and their arm outstretched and supported. Measure blood pressure in both arms using an appropriate cuff size. If the difference in readings between arms is more than 15 mmHg, repeat the measurements. If the difference in readings between arms remains more than 15 mmHg on the second measurement, measure subsequent blood pressures in the arm with the higher reading. Automated BP. Palpate the radial or brachial pulse before measuring blood pressure. Be aware that automated devices may not measure blood pressure accurately if there is pulse irregularity, for example, due to atrial fibrillation. If pulse irregularity is present, measure blood pressure manually using direct auscultation over the brachial artery. Postural hypotension. In people with symptoms of postural hypotension, falls or postural dizziness, measure blood pressure with the person either supine or seated. Measure blood pressure again with the person standing for at least 1 minute before measurement. If the systolic blood pressure falls by 20 mmHg or more when the person is standing, measure subsequent blood pressures with the person standing. BP targets advice and monitoring. Lifestyle advice. Offer lifestyle advice and continue to offer it periodically. Diet and exercise. Explain that a healthy diet and regular exercise can reduce blood pressure. If the person is overweight or obese, offer weight loss advice. Caffeine. Discourage excessive consumption of coffee and other caffeine-rich products. Dietary sodium. Encourage people to keep their dietary sodium intake low by reducing or substituting sodium salt, as this can reduce blood pressure. Be aware that salt substitutes containing potassium chloride should not be used by older people, people with diabetes, pregnant women, people with kidney disease, and people taking some antihypertensive drugs, such as angiotensin-converting enzyme inhibitors and angiotensin II receptor blockers. Encourage salt reduction in these groups of people. Smoking. Offer advice and help to smokers to stop smoking. Alcohol. If the person drinks excessively, encourage a reduced intake because this can reduce blood pressure and has broader health benefits. Offer patient information leaflets on hypertension. For example, the National Institute for Health. H and Care Excellence, NICE, have produced a patient decision aid on treatment options for hypertension to help people and their healthcare professionals discuss the different types of treatment and make a decision that is right for each person. Other information leaflets include those on blood pressure from the British Heart Foundation, BHF, and hypertension and diet from the British Dietetic Association, BDA. BP targets. The aim of treating your high blood pressure is to make it less likely you'll get cardiovascular disease, or stop it getting worse if you already have it, although there is a chance that these things could still happen. High blood pressure is just one of several things that can lead to a stroke or a heart attack. Use clinic blood pressure measurements to monitor the response to lifestyle changes or drug treatment in people with hypertension. Aim to reduce blood pressure and maintain it at the following levels. Adults aged under 80 years. Clinic blood pressure below 140/90 mmHg. Adults aged 80 years and over. Clinic blood pressure below 150/90 mmHg. For people with hypertension identified as having a white coat effector, masked hypertension, consider ambulatory blood pressure monitoring ABPM or home blood pressure monitoring HBPM, in addition to clinic blood pressure measurements. For those monitoring with ABPM or HBPM, aim to reduce and maintain blood pressure at the following levels. Adults aged under 80 years. ABPM, HBPM below 135/85 mmHg. Adults aged 80 years and over. ABPM, HBPM below 145/85 mmHg. Be aware that the corresponding measurements for ABPM and HBPM are 5 mmHg lower than for clinic measurements. For people who use HBPM, ensure that they are trained on how to use the home blood pressure monitors. Provide information on what they should do if they are not achieving their target blood pressure. When using ABPM or HBPM to monitor the response to treatment in adults with hypertension, use the average blood pressure level taken during the person's usual waking hours. For people with hypertension who choose to self-monitor their blood pressure, advise them to use HBPM. Ensure that they are trained on how to use the home blood pressure monitors. Provide information on what they should do if they are not achieving their target blood pressure. When using HBPM to monitor the response to treatment in adults with hypertension, use the average blood pressure level taken during the person's usual waking hours. People with frailty or multimorbidity, use clinical judgment. For people with type 2 diabetes or symptoms of postural hypertension, and people aged 80 years and over, measure standing as well as seated blood pressure. In people with a significant postural drop or symptoms of postural hypertension, treat to a blood pressure target based on standing blood pressure. If the systolic blood pressure falls by 20 mmHg or more when the person is standing, review their treatment. Consider referral to specialist care if symptoms of postural hypertension persist. Use the same blood pressure targets for people with and without cardiovascular disease. Provide an annual review of care to discuss the person's LE. These recommendations do not apply to people with type 1 diabetes or chronic kidney disease, EOCKD, or to women who are considering pregnancy, pregnant, or breastfeeding. At the annual review, encourage adherence to treatment. If necessary, use interventions to overcome medication non-adherence, such as suggesting the recording of medicine taking, encouraging monitoring of the condition, simplifying the dosing regimen, and/or using a multi-compartment medicine system. Offer lifestyle advice. Consider factors such as smoking, weight, diet, and physical activity, and offer advice and support where appropriate. Check blood pressure. If the person's blood pressure is above the target range, confirm that IT is persistently raised by rechecking blood pressure on 2-3 occasions over the next few weeks or months, depending on clinical judgment. Or, if a white coat effect is suspected, considering ambulatory blood pressure monitoring ABPM or home blood pressure monitoring HBPM. If blood pressure is persistently raised above the target range, ensure that secondary causes for hypertension have been excluded and consider additional antihypertensive drug treatment. If the person's blood pressure is within the target range but adverse effects of the current antihypertensive drug treatments are unacceptable, consider an alternative antihypertensive drug treatment. If the person's blood pressure is within the target range and the treatment is well tolerated, review the person in a further 12 months. Check renal function by measuring serum creatinine, electrolytes, and estimated glomerular filtration rate, eGFR, and urine to check for albumin-creatinine ratio, ACR. If the eGFR is less than 60 ml min, 1.73 m2 and/or the urinary ACR is 3 milligrams ml or more, indicating possible chronic kidney disease. For people who are not on an antiplatelet drug or a statin, reassess their cardiovascular disease risk using the Q-Risk assessment tool. Consider a trial of stopping or reducing antihypertensive drug treatment for people whose blood pressure has been well controlled for years and who have favorable factors, such as use of only one antihypertensive drug. Younger age, lower blood pressure, hypertension identified as having a white coat effect, and the successful implementation of lifestyle measures, such as weight loss, reduced alcohol consumption, regular exercise, and restriction of salt consumption. Withdraw antihypertensive drugs gradually, following the manufacturer's guidance, and follow up the person carefully, for example, at 4 weekly intervals for 6 months, then 2 or 3 times a year, to detect any recurrence of Management by stage. For those with stage 1 hypertension, discuss starting antihypertensive drug treatment, in addition to lifestyle advice. With people aged under 80 years with persistent stage 1 hypertension who have one or more of the following: target organ damage, established cardiovascular disease, CVD, renal disease, diabetes, an estimated 10-year risk of CVD of 10% or more. Consider antihypertensive drug treatment in addition to lifestyle advice for people aged under 60 years with stage 1 hypertension and an estimated 10-year CVD risk below 10%. Bear in mind that 10-year cardiovascular risk may underestimate the lifetime probability of developing CVD. Consider antihypertensive drug treatment in addition to lifestyle advice for people aged over 80 years with a clinic blood pressure of over 150/90 mmHg. Use clinical judgment for people with frailty or multimorbidity. Discuss with the person their individual CVD risk and their preferences for treatment, including no treatment, and explain the risks and benefits before starting antihypertensive drug treatment. Continue to offer lifestyle advice and support them to make lifestyle changes whether or not they choose to start antihypertensive drug treatment. For adults aged under 40 years with hypertension, consider seeking specialist evaluation of secondary causes of hypertension and a more detailed assessment of the long-term balance of treatment benefit and risks. Monitor response to lifestyle changes or drug treatment. Those with stage 2 hypertension offer antihypertensive drug treatment in addition to lifestyle advice to adults with persistent stage 2 hypertension. Regardless of age, use clinical judgment for people with frailty or multimorbidity. For those with stage 3 or stage 4 hypertension, the key to its correct management is a slow reduction, even in hypertensive emergencies. Rapid reduction may result in cerebral infarction. Hypertension immediately following intracerebral events is not uncommon and may aid cerebral perfusion. It does not usually warrant intervention. Seek expert advice on treatment. Moderate hypertension, diastolic BP 5 mmHg secondary hypertension is rare and should not be pursued unless there are clear clinical or biochemical clues. Check Fundy, creatinine, ECG for end organ damage, urine dipstick. Check for radiofemoral delay and renal brutes. Identify cardiovascular risk factors and treat if necessary, for example, diabetes, hypercholesterolemia, smoking. Most patients will require more than one agent. Severe diastolic BP-GT 5 mmHg management is similar to that for moderate hypertension, although repeat measurement is less important. Patients with accelerated phase, malignant hypertension should be admitted to hospital. They have evidence of end organ damage. Atenolol 50 mg oral OD if no contraindication. An alternative would be nifedipine LA 30 mg orally OD. The second drug could be added after 24 hours. General principles of management. A single antihypertensive drug is often inadequate in the management of hypertension, and additional antihypertensive drugs are usually added in a stepwise manner until control is achieved. Titrate to the optimum or highest tolerated dose at each step before adding further treatment. Offer people with isolated systolic hypertension, systolic blood pressure 160 mmHg or more, the same treatment as people with both raised systolic and diastolic blood pressure. When choosing antihypertensive medication for people of Black African or African Caribbean family origin, consider an angiotensin receptor blocker, ARB, in preference to an angiotensin-converting enzyme ACE inhibitor. ACE inhibitors and ARBs should not be used in women who are pregnant, planning pregnancy, or breastfeeding unless essential, in which case benefits and risks should be discussed with the woman. Use generic drugs where appropriate to minimize cost. 1. ACE-ARB cannot be used in pregnancy, women under 60. 2. The goal of monitoring is to keep BP under 140/90ths. Those above 80 years goal is to keep under 150/90ths. This is why classification into stages of HTN doesn't guide therapy, but are only useful to know whether someone is in stage 3 and stage 4 when action is required. 3. Allow 2 weeks period for ACE to work, allow 4 weeks for ARBs to work. 4. Beta blockers do not have combination preparations in market. 5. For CCB, usually amlodipine is used. 6. It's better to add in another class than to keep increasing the same class in order to avoid side effects. 7. It's okay to switch classes, especially when SE occur, e.g. amlodipine may be cut if leg swelling and switch to RBHCTES, PrEP. 8. Certain preparations are good for some comorbids with HTN, e.g. for heart failure, ACE-ARB, beta blockers, diuretics, spironolactone are best. For myocardiac infarction, CAD, ACE-ARB, and BB are best. For strokes, ACE and diuretics are best. For peripheral vascular disease, CCB is best as it causes vasodilation. Stepwise treatment of hypertension. Step 1 treatment. For an ACE inhibitor or an RB, first line for people who are aged under 55 years and who are not of Black African or African Caribbean family origin, have type 2 diabetes, irrespective of age or family origin. As above, use an RB in preference to an ACE for people of Black African or African Caribbean family origin. If an ACE inhibitor is not tolerated, for example, because of cough, offer an ARB. Do not combine an ACE inhibitor with an RB to treat hypertension. Offer a calcium channel blocker, CCB, first line for people who are age 55 years or over and do not have type 2 diabetes, are of Black African or African Caribbean family origin and do not have type 2 diabetes of any age. If a CCB is not tolerated, for example, because of edema, offer a thiazide-like diuretic, such as indapamide. If there is evidence of heart failure, offer a thiazide-like diuretic, such as indapamide. If starting or changing diuretic treatment for hypertension, offer a thiazide-like diuretic, such as indapamide, in preference to a conventional thiazide diuretic, such as bendroflumethiazide or hydrochlorothiazide. For people already having treatment with bendroflumethiazide or hydrochlorothiazide who have stable, well-controlled blood pressure, continue with their current treatment. Step 2 treatment. Before considering next step treatment for hypertension, discuss with the person if they are taking their medicine as prescribed. Support adherence to treatment, in line with the National Institute for Health and Care Excellence, NICE, guideline on medicines adherence. If hypertension is not controlled with step 1 treatment of an ACE inhibitor or ARB, offer the choice of one of the following drugs in addition to step 1 treatment, a CCB or a thiazide-like diuretic. If hypertension is not controlled with step 1 treatment of a CCB, offer the choice of one of the following drugs in addition to step 1 treatment. An ACE inhibitor or RB, consider an RB in preference to an ACE inhibitor in people of Black African or African Caribbean family origin, or a thiazide-like diuretic. Step 3 treatment before considering next step treatment for hypertension. Review the person's medications to ensure they are being taken at the optimal tolerated doses. Discuss adherence to treatment, in line with the NICE guideline on medicines adherence. If hypertension is not controlled with step 2 treatment, offer a combination of an ACE inhibitor or RB. Consider an RB in preference to an ACE inhibitor in people of Black African or African Caribbean family origin, and a CCB and a thiazide-like diuretic. Step 4 treatment. If hypertension is not controlled in people taking the optimal tolerated doses of an ACE inhibitor or an RB plus a CCB and a thiazide-like diuretic, regard them as having resistant hypertension. Before considering further treatment for a person with resistant hypertension, confirm elevated clinic blood pressure measurements using ambulatory or home blood pressure recordings. Assess for postural hypertension. Discuss adherence to treatment, in line with the NICE guideline on medicines adherence. For people with confirmed resistant hypertension, seek specialist advice or add a 4th antihypertensive drug. For people with a blood potassium level of 4.5 mmol or less, Consider further diuretic therapy with low-dose spironolactone. Use particular caution in people with a reduced estimated glomerular filtration rate because they have an increased risk of hyperkalemia. Monitor blood sodium and potassium and renal function within 1 month of starting further diuretic therapy, and repeat as needed thereafter. For people with blood potassium level of more than 4.5 mmol, consider an alpha blocker or beta blocker. If blood pressure remains uncontrolled in people with resistant hypertension taking the optimal tolerated doses of 4 drugs, seek specialist advice. For people with hypertension and cardiovascular disease, follow the recommendations relevant to their specific condition. For people with hypertension and cardiovascular disease, follow the recommendations relevant to their specific condition. These recommendations may not apply to women who are considering pregnancy, pregnant, or breastfeeding.